Obstetric emergencies are commonly tested in final exams for medical students. In this video, I will discuss how to answer in an obstetric emergency VIVA. Usually, your examiner will give a real-life case scenario as the lead-in. First tip to build up your answer is to imagine that you are facing the emergency situation as the house officer. Let's look at one example. Read the case carefully. A 34-year-old para 2 was sent to the labor ward for augmentation of labor after spontaneous rupture of membranes. She was commenced on oxytocin infusion 2 hours ago. You were called to see as the CTG was abnormal. Your examiner might give a CTG for you, or he will interpret the CTG for you. Look at the CTG carefully. The CTG shows a prolonged fetal bradycardia, which is more than 3 minutes. This is an obstetric emergency which can lead to fetal hypoxia. When you see a CTG like this, 4 things should come into your mind which can cause acute fetal hypoxia. Namely, they are cord prolapse, uterine hyperstimulation, placental abruption, and uterine rupture. Keeping those 4 in mind, let's move to the questions. Invariably, the first question would be, how will you act in this situation? Let's look at the CTG again. The first step is answering is to interpret the CTG. You have to interpret the CTG as the CTG shows prolonged fetal bradycardia for more than 3 minutes, which is an obstetric emergency, as the fetus can go into acute hypoxia. You will be managing 2 people. One is the mother and the other is the fetus. Always the mother comes first. Therefore, when answering, you have to ensure that the maternal well-being is satisfactory first. So you have to immediately attend and ensure maternal well-being. By looking at the vitals, talking to the mother, you have to ensure the maternal well-being is satisfactory. If the maternal status is satisfactory, then you will have to start the steps of intrauterine fetal resuscitation. Namely, if the oxytocin infusion is still running, you have to stop it immediately, put the woman into the left lateral tilt, start IV fluids with the cannula, and don't forget to call for help, as if the bradycardia continues, you will have to perform a category 1 cesarean section to immediately deliver the baby. If you suspect uterine hyperstimulation, you can consider giving tocolytics. Let's recap the answer. First, interpret the CTG and say that it's a prolonged bradycardia, which is an obstetric emergency, and ensure the maternal well-being is satisfactory. Then start the steps of intrauterine fetal resuscitation. If you have not already answered, the examiner might ask the differential diagnosis as the next question. As we have already discussed, there are 4 conditions which you have to remember which can give rise to acute fetal hypoxia. Those are uterine hyperstimulation, cord prolapse, placental abruption, and uterine rupture. At this situation, the examiner might lead you to one such emergency situation. You perform a vaginal examination and feel the umbilical cord in the vagina. How will you act now? In this occasion, the examiner is testing your knowledge on cord prolapse. So when you're giving the answer, first tell that it is a cord prolapse. The first step in managing a cord prolapse is calling for help. In this situation, as you are doing the vaginal examination, you have to tell that you will ask the midwife or nurse to inform your seniors and the theatres and prepare as for category 1 cesarean section. as in cord prolapse, the delivery of the baby should be done as soon as possible. In cord prolapse, the hypoxia occurs due to two reasons. One is due to cord compression by the presenting part, and the other is due to cord spasms, either by excessive handling of the cord or due to exposure to the environmental temperature. Therefore, you have to tell the examiner that you will prevent the cord compression and the cord spasms. To prevent the cord compression by the presenting part, you will have to elevate the presenting part with your hand. The woman would be put into the knee chest position where the gravity will dislodge the presenting part to prevent the compression. Don't forget to mention that you will not handle or you will minimally handle the cord to prevent the cord spasms. If the delivery is not imminent, that if the cervix is not fully dilated, the delivery should be done as soon as possible by a category 1 cesarean section. If the cervix is fully dilated and the head is visible, the baby should be delivered by an instrumented delivery, whichever the fastest route. Also, you have to inform the neonatology team to be present to receive the baby. This is how you manage a cord prolapse in a situation where immediate access to delivery or theatre facilities are available in the hospital. This is how you put the woman into the knee chest position. Imagine you are in a peripheral hospital where theatre facilities are not available, or for some reason there's a delay in accessing to the theatre. The examiner might ask, how will you manage the cord prolapse now? Remember, if the theatre facilities are available or if immediate access to delivery is available, you have to deliver the baby as soon as possible without wasting time on other procedures. However, in situations where immediate delivery is not possible, you can do certain other things to prevent vasospasms of the cord and also to prevent the cord compression by the presenting part. You cannot keep your hand inside the vagina until you transfer the woman to a facility where theatre is available. In such cases, you have to fill the bladder with normal saline to elevate the presenting part with the full bladder. Don't forget to empty the bladder before you do the cesarean section. You cannot transfer the woman in the knee chest position as it is dangerous. You have to put the woman in exaggerated Sims position, where the woman will be kept in a left lateral tilt with a pillow below the back. Baby should be monitored continuously with continuous CTG. If available, you can use tocolytics to prevent contractions and further compression of the cord. The tocolytic of choice is subcutaneous terbutaline. You have to accompany the patient with a pediatric colleague in case of an emergency delivery while transferring the woman. Some people advise to put a warm saline pad to wrap the cord around if the cord is outside the vagina to prevent cord spasms, but there's no good evidence on this practice. This is the way you manage a cord prolapse when there's a delay in accessing the theatre or when the immediate delivery is not possible. This is a picture of exaggerated Sims position. So when answering the question of management of cord prolapse, you have to think of two situations. One is when immediate delivery is possible. In such situations, don't waste time. Deliver the baby as soon as possible. Use the knee chest position and elevate the presenting part with your hand. If necessary, or if immediate delivery is possible, if the delivery is imminent, do an instrumental delivery. If you suspect a delay, or if you have to transfer the woman to a different facility, the way to transfer is by filling the bladder to elevate the presenting part, keep the woman in the exaggerated Sims position, and transfer the baby to a facility where theatre facilities are available. This is how you manage a cord prolapse. The next question usually would be, what will you do following the delivery of the baby? So usually, after managing any obstetric emergency, you have to remember three things. One is documentation, number two, debriefing, number three is incident reporting. So after any emergency, you have to answer that you will do these three things. Number one, you have to document the events with the times and the people attended. You have to arrange a debriefing session to the woman and the partner with the consultant, and you have to complete an incident report form. In other countries, this is called a datix. So remember the 3Ds: document, debrief, and datix. If you answer up to this point, you'll be able to pass your emergency VIVA. If the time persists, the examiner might ask a few other questions, like asking for the risk factors for cord prolapse. This is a simple list of risk factors. They can be divided into antenatal risk factors and procedure-related risk factors. Antenatal risk factors would be abnormal or unstable lie, polyhydramnios, floating presenting part, fetus with an abnormality, preterm prelabor rupture of membranes. Procedure-related risk factors would be artificial rupture of membranes with high presenting part, vaginal manipulation of the fetus like manual rotation of the head, internal podalic version or reali with external cephalic version. You can add few more risk factors to this list. How can you avoid the effects of cord prolapse? Remember, you cannot predict a cord prolapse. However, you can reduce the effects of a cord prolapse by doing certain things. If you can identify the high-risk women and admit them after 37 weeks, you will have emergency delivery facilities if an adverse event occurs. So, elective admission of patients with high-risk factors after 37 weeks, like transverse lie, unstable lie, would reduce the effects of cord prolapse, as emergency delivery facilities are there if a cord prolapse occurs. Similarly, for a woman with preterm prelabor rupture of membranes with abnormal presentation, there's high risk of cord prolapse. So if you give inpatient care, the chances of adverse events would be minimal in an event of cord prolapse. If you detect cord presentation on your vaginal examination, you have to call for help and plan cesarean section. Cord presentation is the situation where you can feel the cord in between the presenting part and the cervix when you do a vaginal examination. It may be with or without ruptured membranes. If the presenting part is mobile and high, you should not attempt artificial rupture of membranes without senior help. If you want to perform an artificial rupture of membranes for such case, you have to perform a stabilized induction and artificial rupture of membranes. An arrangement should be made for category 1 cesarean section if the need arises. And always do not do inadvertent upward pressure when you're doing a vaginal examination to dislodge the presenting part, because it can lead to cord prolapse. So this is an example of an emergency VIVA with a case of cord prolapse. Thank you. We will meet with another emergency VIVA soon.